Welcome. I'm Barbara Marcum, the Director of Senior Resources for the City of Westland. With me, I have two doctors today, and we're going to talk a little bit about heart disease. So Dr. Kondur and Dr. Chornoby are here from Garden City Hospital, and we're going to talk a little bit about some of the information and some of the procedures that we're dealing with heart disease today. So Dr. Chornoby, let's start with you first and talk a little bit about what made you decide to go into this particular field.
Actually, interesting story for me. When I was 18, I had an irregular heart rhythm. So I kind of went through...
Like SVT?
Actually, SVT, yes.
That's what I have too.
Yeah.
Okay.
So I went through an ablation, and being kind of naive 18-year-old, I thought, wow, like everyone's so afraid to go to the hospital and stuff. Like this really isn't that bad, But obviously, being 18 and really having a minor procedure isn't what most patients deal with, but I thought that I could help make it a little easier for everyone else.
That's really interesting. I have SVT too. I went through the 6 milligrams of adenosine. With a blood pressure of 240 over 170 or something crazy. Never had the ablation, but then later in my life, all my symptoms just stopped. So, once I didn't have hormones, but I'm telling you, and this is interesting because the cardiologist said, many women have told me that this irregular heart rhythm is linked to hormonal levels. For me, I know it was, but they don't do studies on that. They have not done that thus far, but I've since then have had no symptoms at all. I'm sure it's still there, but nothing to trigger it so far. Right. Okay, Dr. Kondur. What made you decide to be a cardiologist?
To begin with, after my medical school, I started my career in anesthesiology first.
Anesthesiology?
Main stage. So, as a part of rotation, I had exposure to the CCU, a couple of pioneers in the cardiology from Harvard. So, the way they deal with the patients makes the difference in their lives post-heart attacks.
Yes.
That too made me to change my career, 360-degree turn, to change back to medicine and pursue my career in cardiology, followed by interventional cardiology.
Okay, so were you okay? I mean, how many more years did you have to go for that, or did you get it in the nick of time where you didn't take you extra time?
This is 1 year extra because I lost 1 year extra starting my career in anesthesia, so I need to forego that credit. So start back again in medicine, so 1 year.
Well, it actually, that background in anesthesiology probably was a good thing for you, regardless. So that really did add to your expertise.
Yes,
so that
I agree.
Sometimes things are just planned for you. Yeah. All right, let's talk a little bit about heart disease. How many people actually have it, and what it is.
So heart disease is very common. About 92 million Americans have some form of heart disease. It contributes to about 1 in 3 or every 1 in 4 deaths in the United States, and it's accounts for more deaths than cancer and pulmonary disease combined.
And a lot of women too.
Yeah, that's for sure.
Okay. I have a question for you. Like now that we're seeing a lot of sedentary lifestyle with people sitting and on the computer all the time, is that an influence of that?
For sure. The American Heart Association actually has a new campaign or semi-new campaign called Life's Simple 7, and it talks about a healthier lifestyle and makes it pretty simple. One of those things is having a sedentary lifestyle, so encouraging physical activity. Obviously, smoking is a big factor. So if you're smoking, you need to stop, or don't do it if you're not a smoker. Eating a healthy diet, and then like you said, physical activity obviously would lead to some weight loss. That's the first 4, and the last 3 are controlling blood pressure, cholesterol, as well as blood sugar.
I notice here when I'm over at City Hall, it's a big building. There's a lot of walking area, and some of the girls on their breaks, you see them with their little pedometer or Fitbit walking.
Right.
And getting their steps in, while, and taking a break from their desk. So.
Yeah, that's great. That's a great thing to start with. Just getting outside. I know in Michigan it can be tough during the winter, but parking the car down the street and walking somewhere, walking to the restaurant, or even riding a bike. Obviously in the winter, staying indoors or riding a stationary bike would also help you get some exercise.
Okay, so we know that there's heart disease out there. It's probably only going to get worse with the sedentary lifestyle, so education is a big deal. But when those symptoms first appear, or when a procedure needs to be done, what are the options as far as someone who has been diagnosed with a big problem? What are the first things that they look at and some of the options short of cracking you open?
So there is a lot of, because of the technology advancements and a lot of options. If any person diagnosed with a heart disease means blockages significant enough and that is causing their symptoms and lifestyle limiting, then they need to revasculate, means need to open the blockages. Two means you can do that. One, minimally invasive catheter-based therapy, and the other one is cracking the chest open in the old way and putting a conduits like a bypass grafts to the healthy segments to improve the blood flow to the heart muscle. That way you can save the heart muscle and they do better. So because of the advancements in technology, you don't need to cut open. Some patients may not be suitable for the even old patients for the bypass, even younger population. You can do with the minimally invasive catheter-based therapy. So you can take a catheter all the way and look at the blockage is significant enough. You can use the balloon or stent or drug-coated stents to open up the blockage, and that way you can restore the blood flow to the heart muscle so that it can recover, and they can that can put them back into their lives where they are healthy and lead their lives without any symptoms.
Okay, from the information you just gave me, I'm going to dissect that a little bit.
Sure.
And we'll get a little further into that.
Yeah.
Okay, so you're right. As people get older and they're seniors, surgical procedures they don't do as well with, especially big major procedures.
You're correct.
So when you do a catheter in the cath lab, that's where they do the catheterizations. Okay, they used to go in through the femoral artery. What has changed? Now there's kind of an option.
Yeah, the old way is going through the femoral artery, through the catheter to fix it. Now you have other options, like you can, to make the patient comfortable, you don't need to lay down 6 hours post-procedure. So other alternative access is you can go from the wrist through the radial artery, and you can do the same things what you can do through the femoral artery.
Where is the radial artery? Because these veins look too little to have a...
Either you can do through the snuff box or you can do from the radial head.
Snuff box, I haven't heard that. What is that?
It's like just groove between the radial head and like between the thumb and radial head.
Okay, do you have any of that equipment? Is that what you use?
So what we do is, this is a tiny sheath, okay? So once we get access, we put a tiny sheath to the radial artery. Once we secure the radial artery access, and you can use this catheter, where this catheter is a tiny catheter, like a 6 French, means 2 millimeters.
Okay.
So you can go through that sheath all the way to the, so you can go all the way and you can go to the artery where the blockage, okay, you put it together there, and you can pass the wire through this and open up with a balloon like this, and then stent. You can put in a blockage, so you put a stent and you can open up the blockage. So if you see the size of the, before it used to be large bore, diameter sheets, now you can see how tiny, and you can go through the wrist and fix everything without cutting open the chest. So recovery, they don't need to lay down. That's an advantage. Instead of going through the groin, you go through the wrist, and you can lay down, you walk around immediately after the procedure. You don't need to lay down. So it's a comfort to the patient, less complications like no infection. Groin is always the risk of infection because of the unhygienic areas, and bleeding risk. These are all minimal through the wrist. So that's a new technology.
Yes, when my dad had his, they put sandbags on you, don't move, and it's like, well, that was very frightening. But at the end of it's like a little wire. Is there any chance that could like perforate something or not?
There is a risk involved. Every procedure comes with a minimal risk. This is the minimal. And the chance of perforation artery when you're doing the stents through using the wires, balloons, is 1 in 1,000.
Okay, but actually if that happens, you can see it, right?
Yeah.
Is there a dye? Okay, so let's go from the beginning of
Sure.
a catheterization. Is there a dye that you put in so you can see what's happening, or don't you need to do that?
So is a dye used to visualize the arteries.
Okay.
So once you put a catheter, you inject a dye through the catheter to visualize the arteries. Once you see the arteries and you define the how much is a blockage, is 70% or 80% or less than 70%. Anytime if you have a blockage more than 70%, then opening that blockage will help the patients. Okay. So in that case, we use the dye guidance under fluoroscopy under X-ray machine. So you pass the wire, and once you pass the wire through the blockage, using the balloon, you open up the blockage, and then finally we put a stent. The stent is needed to not help the blockage not to recoil back to the where it was.
Good. So
And to stretch it up.
say can you even do that with like 90% blockage?
Yes.
All right, so you put in first the balloon and that opens it up,
Yeah.
and then what you do then is you put in the stent
Stent.
that is like keeps it open, because if
Keeps
you
it
didn't
open.
have it,
Then
it'd
it
close back
collapse.
up,
Yep.
back up again, right?
Yep.
Okay, so then after that, so then you take that out, then the coil,
Yes.
and you leave the stent in. What does a stent look like?
Stent is like a small, tiny mesh made with nitinol and nickel and titanium. It's a material made with the inert material, so that has a good radial strength so that it can keep up the opening of the vessel.
Okay, and I imagine, I'm just curious, that I'm sure they make new materials and there are new things all the time because technology, it changes so quickly.
Yeah.
Have there ever been problems with like stents being recalled or something? And then what do you do as a doctor? How do you make the decision what product you're going to use?
If like we've seen in the past, like stents get recalled, and as long as patient is doing okay, no symptoms, once you deploy the stent, that's it. There is end of it. You cannot retrieve it. And if it is any problem re-narrowing inside the previous stents, when the patients get symptoms, you go ahead and fix it with the new ones.
Okay. Let's talk a little bit about the heart and what it is. So, it is a muscle. How many areas in the heart are there?
Okay. There's 4 chambers of the heart, 2 atria which receive blood and 2 ventricles which pump blood. The left ventricle is kind of the powerhouse of the heart. It's where oxygenated blood then gets drawn in from the left atrium, from the lungs, and then from there, when it gets to the left ventricle, it gets pumped out to the rest of the body.
So when we're talking about like congestive heart failure, is it that left ventricle that's really affected, that's not working properly? Is that what that is?
Yeah, the left ventricle is the main culprit. The right ventricle also plays a role.
Okay.
But the ventricles are the main 2 pumping chambers. Heart failure in general is just inability to pump adequate blood to the body. Sometimes it's from a weak heart muscle, which means it doesn't squeeze well enough, but also over time the heart muscle itself can stiffen. So after it squeezes, it relaxes, and it actually sucks blood in the ventricle, and it can, over time, it becomes very stiff and does not pull blood back in the ventricle from the atrium very well, and therefore resulting in blood backing up throughout the body.
So we see that a lot with senior citizens,
Yeah.
obviously. Okay, so what can be done if this is the case? If it stiffens up and it's not pumping correctly, what can you do for somebody with that problem?
So acutely, or if enough volume or blood is backed up that's affecting the lungs and breathing, we can take volume off with medications like Lasix. And then once the patient has the extra fluid removed, then the medications like beta blockers and ACE inhibitors help relax the ventricle and help relieve some of that stiffness, or even improve the heart function over time if the heart is not pumping well enough. Sometimes those medications can help basically make the heart stronger.
Okay, out of curiosity, and this is something that I think is important for people to know, where are there arteries attached and where are there veins, and what is the job of an artery and what is the job of a vein?
Okay. Let's start with the arteries. The arteries, the left ventricle pumps into the arteries, the biggest artery being the aorta, which supplies blood to the entire body. First, the aorta supplies the heart itself, actually, and the coronary arteries. Arteries in general have multiple layers and actually are muscles because it's got to recoil against or prevent recoil against that strong heart pumping. Veins bring blood back after the body has used it and the oxygen has been used. The veins are weaker, but in general just bring blood back to the right side of the heart, where we talked about earlier, the right atrium and the right ventricle, sends it out to the lungs and gets oxygen and sends it back to the left side of the heart.
Okay, having SVT, okay, I had no idea at that time that the heart is actually an electrical organ. How is that? How does that work? I was shocked when I thought, well, where does that come from? Where does that impulse come from?
So Dr. Kondur is actually the best at explaining it this way, but the heart is a house. So you have the electrician who does who deals with the electrical components, or the plumbers. That's the joke with the interventional cardiologists who take care of the circulatory system. But when you're born or when your heart's formed, you have your heart actually has rhythmic impulses in the cells themselves, and actually called like the sinoatrial node, atrial ventricular node. And then even if those nodes become diseased over time, the actual heart muscle itself has cells that can beat on their own as well. So it's actually a pretty impressive system that if the main impulse system fails, and even the secondary impulse system fails, then the heart itself has its own impulse system, the ventricle. So it's pretty interesting. Nature
is a fascinating thing, isn't it?
Yeah.
Okay, so if that is failing, and we talked about one thing as far as blockages go, and we can do a catheterization or the open heart. What happens when the rhythm is wrong, and there's a problem like atrial fibrillation? What is a pacemaker? How does it work, and when do you put it in, and how do you do it?
I think Dr. Chornoby can answer a non-invasive, but I can answer how much I can. I'm a plumber.
Okay.
He's a master of all as well.
So, okay, yes.
So atrial fibrillation or flutter, both are like irregular beats.
And people can feel that.
Yeah, so basically people feel it like a thumping sensation, or like comes with the dizzy spells, fainting, tiredness, because the heart is not in a sync. The top chambers are like fibrillating, not squeezing completely. That happens, then the blood flowing to the lower chambers are going to be limited.
Right.
So that's why the blood going out of the lower chambers are going to be less also. So you get less blood flow to the vital organs. They feel tired, weak, and dizzy, sometimes faint. Okay. It's a more like electrical problem, like any kind of extra beats coming in the upper chambers, they set the cycle. So there is no clear-cut why it happens. It's more like a neurohormonal association. So some are correctable. People have an electrolyte imbalance, like a low potassium, magnesium, calcium can set off this irregular heartbeat too. High thyroid hormone level also can do that, high or low. And majority of the times is more like a neurohormonal. So no definitive cause, okay, this caused this problem. So it's very hard to identify. The only thing is you treat it when it happens to prevent not to have their stroke and not to have any strokes.
Well, it was very frightening for me because they gave me the 6 milligrams of adenosine and brought in the crash cart.
Yeah.
So at that point, it was like, are you kidding? And it was the strangest thing because when I would get SVT, I would feel like, you know, if you almost get in a car accident, you have that jump of adrenaline.
Yeah.
That's what would start it. And then it would go. And I mean, it went so fast that when I ended up going to the hospital, it was so fast they couldn't even detect the heartbeat. So, but they cheated me out of sirens because I was asymptomatic. So I didn't even get the sirens in my only ambulance ride. But, you know, it was really strange because when they gave me the adenosine, I said, you know, I remember my grandmother had an old transistor radio, and when you turn it off, the sound went, I said, that's just what it felt like. And he said, that's what it feels like to die. And I said, oh my God, I'm so glad you didn't tell me that before you gave me that shot. But it was, and then the heart stops, the medication dissipates, and hopefully the heart starts up with a normal rhythm.
Yeah.
If it doesn't, hence the crash cart, right?
Yeah.
Okay, so with that being said, there are things that people can take. They put me on a beta blocker afterwards, which was good. And so you have the catheter, you have medications that you can give, you actually have solutions if it's happening. Now, what happens if you have atrial fibrillation? I know what they did for me with the SVT. What can they do for somebody with the atrial fibrillation?
So atrial fibrillation is another beast, another segment, is a more like a fast heartbeat.
And it's a different place
It's a
in
different,
the heart, isn't
like
it?
it can come from anywhere. As he said, Dr. Chornoby, heart is electrically active. Each and every cell can throw a beat and sets a cycle. So it could be right-sided, it could be left-sided. Source could be anywhere. And sometimes even very hard to identify for electrophysiologists. Takes 2 to 3 hours.
You have to wear, well, and sometimes the Holter monitor, they told me we can't diagnose you until we can see it. We can, and then once we see it, we know exactly what the problem is.
Yeah.
So that's kind of a way to figure it all out.
So Holter monitor will help you. Some people can throw irregular heartbeat like atrial fibrillation sporadically. It's not like a constant. So when you go to the physician office, you do the EKG, it's completely normal. So you say, I'm feeling irregular heartbeat. Those are the scenarios. They give a Holter monitor, event monitor, like you wear it for long, 30 days, 15 days.
Yes.
So to see how bad is the irregular heartbeat, what is the burden, like atrial fibrillation, how often it's happening. So once they know that, they can tailor the therapy accordingly with the medications. If the burden is too much and your symptoms are not tolerable, limiting your lifestyle, they can go through the catheter-based therapy. Means they go through the vein from the same femoral vein instead of artery, go all the way. They find the circuit where it is causing the fast heartbeat. They put a small circuit breaker, like a burn there with a radio frequency. So that will abort the
that's the ablation where they just burn it.
Burn it.
You know, because I don't know, I'm going to ask if this is true, I really don't know. You can have a severe symptoms with kind of a mild case, or you can have mild symptoms with a very severe case. And only looking at it, when they diagnose it, can you tell what's happening there?
It's purely symptom driven.
So what would you say if somebody, what kind of symptoms would you say if somebody observes that they need to see a cardiologist?
So most of this, like people, if they have risk factors, like they have a hypertension, smokers, overweight, diabetes, and a strong family history. Anybody in the family who had a premature heart disease, like below 50, these are the people they put you at the risk for having a blockages. So if you feel like symptoms like any chest heaviness, this is typical. Some atypical presentations like indigestion, jaw pain, neck pain, shoulder pain, and feel like some decreased exercise tolerance. They are doing fine all of a sudden this year, they are not able to perform what they were doing last year, that we call as a decreased in the exercise capacity, and feel like fatigue, tired, unexplained. So these are the symptoms with the risk factors. They need to seek help right away, to go to their cardiologist, need to be worked out.
Okay, Dr. Chornoby, what are the good things that people can do when we talk about being heart healthy? And we've done segments and a lot of education on diabetes and the heart. What are some great things that people can do to keep their heart healthy?
So just staying active, we kind of talked about that. Physical activity, when we're evaluating people for coronary disease or heart disease, one of the best predictors of how long you live for or how low or high your risk is how much like work or exercise you can do. So if you're, everybody's a little different. I mean, if you're 20 or 30 and no medical problems, it means, yeah, you should be doing, 60 minutes probably 5 times a week. Obviously, if you have trouble with, as you age, you get, joint pains and stuff like that. You need to stay within yourself and, exercise as much as possible. Regular checkups, staying, high cholesterol doesn't show up just by, looking at, even regular doctor's visits, unless you draw on the blood, you don't know how high your cholesterol is, and that's a big risk factor for heart disease. Same with blood pressure. It's called the silent killer because your blood pressure is, usually not symptomatic. You usually don't have symptoms from having high blood pressure, although you can. So, and same thing with having diabetes or glucose. So, being aware of all these conditions is very important. So, treating them appropriately going forward will reduce your risk of heart disease greatly in the future.
Okay. This is Health Matters. We deal with a lot of people watch this, not just seniors, but if you're a senior and you've had a sedentary lifestyle and say you're 60 years old, how should you go about starting to increase your exercise? Can you go gung-ho and go out and, fast walk for an hour, or should you start out with 20 minutes, or how should you proceed?
I would start out slow. I would talk to your doctor. Reason being, if you go from having a sedentary lifestyle to trying to run a marathon, it can be very dangerous. So make sure that you are, healthy first and cleared by your doctor. But yeah, take it slow and work yourself up. And even if the knees or you can't walk, we have
new steps.
Exactly.
We have ways for people to do that.
Right. So I think it's just about finding what's right for you and consulting with a professional, whether it's at the gym or there's plenty of resources available.
Okay, well, I want to thank you both for being here. We kind of got a little of an education and those kind of, I got to tell you, aren't as scary as what you might think. So that makes me feel better should I ever need one of those. But I'd like to thank you both for taking time out of your very busy schedules to be with us today and help us a little with community education. It's a big deal. So sometimes this is the only way that, people hear about what's happening and what they should do. So I thank you both for that.
Thank you very much for allowing us to participate in this program.
Well, thank you.
Awareness. Yeah.
Thank you.
Thank you.
And thank you, friends in the viewing audience, for being with us today.